Lastly, I want to talk about prone positioning for an ARDS patient. This would certainly be a last-ditch effort to help improve the patient's health, but there are some key indications that must be considered prior to placing an ARDS patient in the prone position. First, ventilation has to have been optimized, i.e. the pressure control ventilation, inverse inspiratory and expiratory ratio, increase in the PEEP, and monitoring for the effects. Despite optimizing the ventilation, a PaO2 and an FiO2 of 150 or less, PEEP of 7.5 or more, pulmonary artery occlusion pressure of less than 18 millimeters of mercury, and bilateral infiltrates on an anterior-posterior chest X-ray may be considered as well for indications for prone positioning. There are also certain exclusion criteria that must be taken into account prior to movement of an ARDS patient. These include, but are not limited to, a DNR order, asthma, head injury with a raised intracranial pressure or ICP, patients experiencing seizures, spinal injury requiring spinal precautions, recent abdominal surgery or an open abdomen, pregnancy, which would be delegated for the second or third trimester, an open chest, and any ventricular assist device or an intra-aortic balloon pump, a new trach that had been placed within the last 24 hours, maxillofacial surgery, so any facial surgeries, recent pelvic or chest fractures, or the patient is hemodynamically unstable. If any of these pertain to the patient, they will be excluded from being placed in a prone position. So after consideration of the exclusion criteria and risk assessment, and the patient has been deemed suitable for the use of the prone position, the following measures should be undertaken. Eye and mouth care done, checking the PERLA before and after turning, check all central venous and arterial access sites for inflammation and change them if need be, ensure endotracheal tube and trach tape has been checked and secured all the way, trach care and dressing changes if necessary, document where the ET tube is at the teeth, assess the patient's level of sedation, so give them more if they need it, disconnect any non-essential IV lines, and reconnect following the turn while also taking consideration the length of the IV lines. Lastly, anesthesia will take responsibility for turning the patient's head and the safety of the ET tube. During the turning procedure, the patient should be disconnected from the ventilator. There aren't any special techniques for placing the patient in a prone position, but the turning procedure should only be performed when there is sufficient personnel available. If necessary, a hoist lift may be used if the patient is much larger. In order to assess the effectiveness of the prone position, note the patient's oxygen saturation, the SpO2, in the supine position prior to turning the patient into the prone position. If it drops below the supine value for more than 10 minutes, turn back to the supine position. If the patient responds to the prone position by increasing the SpO2 beyond that achieved in the supine position, take an ABG after an hour and calculate the OI or the oxygen index. Also, an ABG sample may be taken before placing the patient in the prone position. Once back in the supine position, take another ABG and calculate the oxygen index. If the patient's oxygen status deteriorates, so an oxygen index of less than 150 in the supine position, return to the prone position. Something to consider while the patient is in the prone position is prevention of skin breakdown, more specifically on the patient's head and neck. Before placing the patient in the prone position, take note of the patient's natural posture. They may have a fixed kyphosis or condition such as rheumatoid arthritis or cervical spondylosis. To prevent any skin breakdown at the patient's head and neck, the head of the bed may be elevated to try and minimize facial edema. In principle, the head should be placed in a position that the neck is not extended and the head is not being supported by the mattress alone. If the use of the pads for a head support is to be considered, it must be discussed with the physiotherapist prior to the placement. While being secluded to a bed is known that the stimulus of soft tissue deterioration is from the lack of movement. Muscles have become shorter and stiffer. If joints are forcefully moved when they become stiff, micro tears in the muscles and other soft tissue structures around the joints may occur. These torn fibers will then begin to bleed, which may result in calcification. This calcium builds up and in turn will cause extreme pain for the patient, resulting in less mobility. After stretching, overstretching is a possibility of occurring as well. So it's important to maintain soft tissue length and mobility within a normal range of motion and in normal resting postures. Also, patients are generally repositioned every 2 to 4 hours. So a patient in the prone position should also have their position modified every 2 to 4 hours as well to prevent any skin breakdown or pressure ulcers. Next, I want to show some examples of before and afters of patients that were not in a prone position on a CT and an X-ray compared to afterwards, and then they took a CT and X-ray and see the outcome. Also, I want to demonstrate how the prone position is, how they may be placed in it and what position and what it kind of looks like. So as mentioned before, I was going to show you some visual evidence of patients being before and after being placed on a prone position with x-rays and CTs. So the first one here is a patient's chest x-ray that was presented to the ER with pneumonia. After a few days of being in a prone position on and off, they had, as you can see, some significant improvements. I mean, there's clear definition of the lungs. Whereas here, obviously, everything is just so whited out. I also have a CT of the same patient of the before and after. So over here to the left, before they were placed in the prone position, you can see all of this consolidation that they had in the posterior aspect of the lung. Again, after a few days of being on and off in the prone position, they had some significant improvements in this area of the posterior of the lungs. The last patient that I have had probably been about 17 days on ECMO. They had literally nothing else to do that they could think of, nothing would work. So they decided to put the patient on in a prone position. After day 3, not a whole lot of improvement from here to there, but then obviously after 5 more days after that, this lady had some significant improvements over here, and they say that she was about 99% improvement from pre and post prone position, and then obviously she was decannulated from the ECMO just right before this. So these x-rays and CTs can certainly show some major improvements in what a prone positioning can really do for these patients. So here I'm going to demonstrate how to roll a patient, briefly demonstrate how to roll a patient into a prone position. So Michelle here is going to be my patient. So first you want to make sure that there's even an order for the patient to be in a prone position. You want to make sure that all of the checklist has been done, that they don't have any exclusions that would prevent them from being in a prone position. And then prior to that, you want to make sure that all of your pre-care, like your mouth care, eye care, and stuff like that, has already been prepped. Your patient's IVs have all been taken care of if they needed to be changed or anything, all that good stuff. So once you've gotten all that out of the way, you will gather up some pillows and sheets, which I have some pillows. You will get approximately about 4 people to help roll, and then 1 person to secure the airway. So to begin, make sure that all your catheters and everything is down to the side. Going to disconnect the IVs, of course, and disconnect the patient from the ventilator. So to begin, we're going to tuck the sheets up underneath the patient, just like so. And then make sure that the airway is secure. And then in a fast motion, well in this case, fast-paced motion than what it would be in real life, you're going to roll the patient to the side. So in this position, you can either go all the way, depending on whoever's in charge decides that they want to do. If they want to go all the way, or if they just feel comfortable going halfway first. So in this case, we're going to go halfway, make sure that everything is still secured, all the catheter lines and everything are still good. And then from there, we're going to continue to roll the patient into the prone position. So the actual prone position, this patient will have their arm up in this position here. We're going to put a pillow up underneath there. And then we'll take their leg and put it up like this with a pillow supported up underneath. So this position right here would just be your general prone position, which will ultimately help with oxygenation.